Hi everybody and welcome to the 2016 protocol in service for the West Virginia Office of EMS, ALS and BLS protocols. This presentation will show mostly ALS protocols as there are more of them and they are often very similar. Any ALS specific material will be highlighted in the red box as you see at the top of your screen. If the protocols are significantly different, both of them will be shown. And for reference, the orange top protocols will be for BLS and the blue label protocols are for ALS. This is the layout of the table and contents as everything's broken down into trauma, cardiac, respiratory, and pediatric, as well as environmental, medical, children with special health care needs, special treatment protocols, then various procedural protocols, as well as special protocols, and then the appendices. So with using the protocols, you'll see here the title of the protocol by the protocol number, as you could be referenced by the table of contents. Classifications of the protocols, as there are more, are the 1000 series, CCT, as well as the 2000. 3000 protocols applied to the C3IFT, interfacility transport protocols. 4000 paramedic, 5000 is open for various, and 6000 for EMT. Then it breaks down to procedural protocols. If you see the icon of the telephone, it means that operation or protocol requires consultation with medical command. If you see the picture of a physician, that means contact directly via medical command to speak to a physician. For the purpose of these protocols, any patient under the age of 12 will be considered a pediatric patient. We'll begin with protocol 4101, as this is the ALS protocol of the 4000 series. The BLS protocol looks identical to this, being 6101. The only difference being, as you see in the red box, the algorithm shows considering pain management at the end. So with severe bleeding, if the bleeding is controlled, yes, just apply appropriate pressure dressing and consider pain management for the ALS providers. If the bleeding is not controlled, if it's on an extremity, apply a tourniquet. If the bleeding is not controlled after that, consider a second tourniquet. And also further on to that, consider the hemostatic agents. If it is not an extremity, just use pressure and pressure. If it's an open chest wound, hemostatic agents, or with not hemostatic agents for open chest wounds, continue direct pressure. If it's not an open chest wound, go straight to hemostatic agents and pressure dressings. For spinal immobilization, determining whether to immobilize or not immobilize a patient, starting at the top, is there any kind of neurological deficits? Are they paralyzed? Do they have loss of sensations anywhere? If yes, immobilize. If no, do they have an altered mental status? If they do, immobilize. If they do not, you can continue on. Any kind of chemical impairment? Are they on drugs? Are they drunk? If so, immobilize. Is there any kind of distracting injuries, such as broken femur, anything like that? If there is, it may take away from whether you can assess their spinal injuries. Immobilize. Do they have any point or tenderness over the spinal process? If they have back pain when you touch them, immobilize. Do they have any kind of pain in their neck whenever they rotate it or bend it 45 degrees to the left or the right? If they do, immobilize. If not, if they do not meet any of that criteria, they are not required to be immobilized. Or always just err on the side of caution or go with your gut instinct if you feel like you need to immobilize them. So spinal trauma, basically the protocol just goes over how to do your assessment of spinal trauma, checking mechanism of injury, doing your complete rapid trauma assessment, checking for any pain or tenderness, ensuring PMS is still in store, checking for any kind of deficits, any suspicion it could cause that altered mental status. And it continues to go over more assessment criteria of checking for risk mechanisms, using the nexus criteria of seeing if there's any neurological things, any kind of midline tenderness, distracting injuries, intoxication, following along that previous algorithm of whether to immobilize or not. Then going over extrication of patient to a stretcher. If they don't have any pain and they're entrapped or they need to be removed out of a scene, that they can self-extricate if they do not have pain. If they do have pain, you need to make all precautions of stabilizing their spine. With chest trauma, if they have a flail segment, first and foremost, stabilize it. Seal any open kind of wounds, taping 3 sides of an occlusive dressing. Now for ALS only, if you see signs of a tension pneumothorax, such as hypotensive, changing mental statuses, perform a chest decompression and refer to that protocol. That will be covered later of how to perform that. Chest pain after trauma is a significant injury. Do not treat that patient for chest pain. Nitro should not be given without MCP order for chest pains after that. If the tension pneumo develops a sealed sucking chest wound, attempt to resolve by releasing air from that 3-sided tape of the occlusive dressing prior to any kind of decompression. Chest decompression is only indicated for true tension pneumothorax. With abdominal trauma, just provide rapid transport. If there's anything penetrating, stabilize it, control bleeding, any kind of eviscerations, cover the evisceration with a moist, sterile dressing, and apply occlusive dressing to that evisceration. Any blunt trauma, just recognize and assess proper transport. If they're in shock, refer to the shock protocol and consult with medical command for any questions. Musculoskeletal trauma, just treat all painful, swollen, and deformed areas as fractures. Stabilize the patient and their extremities before transporting. And with ALS, if there's an isolated injury, refer to the pain management or patient comfort protocol. With a pelvic injury, stabilize, monitor closely, and be checking for shock. If there is a total or partial amputation, wrap the severed part in sterile gauze, slightly dampen normal saline, and put it in a sealed container, waterproof bag, and immerse that in ice water. Head trauma, good head-to-toe assessments. If there are any signs of herniation, such as the increased blood pressure, bradycardia, the altered mental status, dilation of one pupil, paralysis, or any kind of posturing, ventilate the patient 12 to 20 breaths per minute. Maintain an end tidal of 30. If there are no signs of herniation and they need ventilated, ventilate 10 to 12 breaths a minute. Maintain an end tidal of 35 to 40. And for ALS, IVs. Elevate the head 30 degrees above horizontal to prevent any kind of furthering head injuries. And perform neurological assessments every 5 minutes. And then perform your assessments if you find anything such as hypoglycemia, they seize, refer to those respective protocols. For hypoperfusion, various categories of shock that can cause a hypoperfusion, a little bit in-depth verbiage as to what those types are, how to help identify those. And for ALS, as soon as possible, establish 2 large bore IVs. If their blood pressure is below 90, give them a bolus of 20 cc's per kilo up to a maximum dose of 2 liters. If they need more fluid and they're still hypotensive, consult with medical command. If you feel hypovolemic shock, the next bolus must be from medical command. If the blood pressure is good, no other signs, symptoms, administer fluids, KBO 100 cc's per hour of normal saline. If distributor shock, if the blood pressure is below 90, give a bolus of 20 per kilo. If you need to do a pressor, like dopamine, you need to call medical command to get orders for that. If it's cardiogenic shock causing hypertension, a bolus of 250 cc's to make sure you're not fluid overloading the patient. Once again, if you need dopamine for the cardiogenic shock, you need to contact medical command. For the EMT, manage the airway and give them oxygen, control bleeding, and prevent heat loss. Consider asking for ALS backup or air medical if needed. If you find anything else during your assessment, refer to that respective protocol. For traumatic arrest, if you arrive on scene and find a patient pulseless and apneic in cardiac arrest due to trauma, begin CPR and maintaining C-spine protection. Establish and secure an airway, whether intubation, such as the ALS protocol, or via King tube, the BLS protocol. Do full mobilization, limit on-scene time. If patient's entrapped or you're considering cease efforts, refer to the cease efforts protocol 9102. For burns, the various types of burns breaks down what you do thermal burns. So thermal burns, flush the burned area with tepid water, sterile if you can. Do not attempt to wipe off any grease, tar, anything on the skin, and do not apply ice. Dry the body if the burn area is above 10% to prevent hypothermia. For dry chemicals, brush off the powder first, then flush with a bunch of water for at least 20 minutes. For liquid burns, flush the area with copious amounts of sterile water for at least 20 minutes and continue that on the way to the hospital. And for ALS, consider pain management for those major burns. If they're in shock, treat per the shock protocol. With electrical injuries, be sure that you perform a 12 lead and at the BLS level, transmit that to ALS, interpret that to make sure there are no lethal dysrhythmias. For chemical burns, if need be, you can request hazmat teams to handle it if you are unable to, and contact medical command if you need any help identifying substances or know exactly what treatment to do with that. This protocol also gives some common chemicals that may cause burns, of what to do with them. In this protocol is a reference of the minor burn criteria and major burn criteria based on the rules and nines for adults and pediatrics. So for minor burns, anything superficial and partial thickness. For the adults, anything less than 18. For child, anything under 9. Full thickness under 2%. For major burns, anything the opposite of that. For adult, anything superficial partial thickness over 18. For child, anything above 9. Full thickness, anything above 2%. Partial or full thickness to the face, neck, head, hands, feet, and genitalia. If it interferes or could possibly compromise the airway, all electrical burns and circumferential burns are all considered significant major burns. Those are the ones that are generally going to go directly to a burn facility. For eye injuries, any kind of penetrating thing, just stabilize it, check for bleeding, cover up both eyes, basic first aid stuff. If they have any kind of sudden painless loss of vision, could be a central retina artery occlusion, a stroke, or some kind of embolic event. So just stabilize, provide oxygen, and transport the patients to the closest appropriate facility. At the EMT level, which is also, I'm not sure why this is not included in the ALS protocol, but there is optional tetracaine medicine that can be administered to this patient who do have painful eye injuries. So with that, just administer 2 drops per eye that is being irrigated. And with that tetracaine solution, you'll attach a saline bag to the IV tubing and turn the patient's head to the side and continually flush those eyes out with those bags of saline. And with that tetracaine, it's a single-use medication. Once you open it and use it, you must dispose of the rest. With BLS chest pain, after your assessments, attain a 12 lead and transmit a copy of it to a facility or through medical command. Give your dose of 324 of aspirin unless they have any kinds of signs of active bleeding, such as gums, bloody or tarry stools. As long as their pressure is above 100 and they have not taken Viagra or Levitra within 24 hours or Cialis within the last 72 hours, contact medical command to get orders for nitroglycerin. Always be sure to check the blood pressure in between doses of nitroglycerin. If the blood pressure drops below 100, contact medical command to speak to a physician. If the blood pressure is below 100 and the patient's not taking nitro within the past 30 minutes, this is a life-threatening emergency. Position a patient with a head elevated no more than 15 degrees. Do not give nitro. Request ALS backup. See, in a lot of these BLS protocols, that sometimes they'll say consider ALS backup, but there are a few that will say request ALS backup. And then a note down here of patients who may have pulmonary edema to refer to the CPAP protocol. For ALS only, standing orders on nitro and aspirin. If the 12 lead indicates a stemming or left bundle branch, confirmed by right-sided ECG, means moving that V4 lead over to the right side, transport that to a. If the 12 lead does indicate an inferior MI, confirmed by V4R at a minimum, do not give nitroglycerin. Refer to the right ventricular infarct protocol. If they are above 90, give the nitro, repeat it up to 3 doses. If the blood pressure does drop below 90 or decreases more than 30 below their normal baseline, discontinue giving the nitro and contact the physician at medical command. Or if they've also taken any of the male enhancements, also consult medical command to speak to a physician before giving nitrates. For ALS only, if chest pain persists after the nitroglycerin, you may administer morphine 2 milligrams and repeat that every 5 minutes for a dose up to 10. If they are hypotensive or bradycardic, consider using fentanyl instead. So with fentanyl, 1 microgram per kilogram up to 100 mics, that's single dose via IV. Any additional doses require an MCP order. If the patient is over 55 years of age, you give half the doses. So for morphine, you give 1 milligram slow every 5 minutes up to 10. And for fentanyl, you give 0.5 milligrams per kilogram up to a total dose of 100 micrograms. Any additional doses outside of those, again, require an MCP order. And then treat any dysrhythmias according to specific protocols and their respective ones. If your transport time permits, complete the AHA fibrinolytic checklist found in Appendix A. That is for ALS only. For severe hypertension, again, ALS only. If the patient's blood pressure is over systolic of 240 and or diastolic of 120, and that's taken manually in repeated arms, and they have any serious signs and symptoms such as chest pain, seizures, deficits, altered mental status, blurred vision, shortness of breath, or headache, and that is not related to a neuro response from a traumatic brain injury, you must contact medical command to administer labetalol or nitroglycerin or morphine. So to administer labetalol, initial dose is 10 milligrams slow, IV push over 2 minutes. And you may repeat that in 10 minutes if the blood pressure remains above 180. Use caution in that. Patients have asthma or COPD. For nitroglycerin, 0.4 every 3 to 5 minutes. Repeat if the blood pressure still stays over 200. Consider it as a first-line hypertensive in a setting of hypertensive crisis with chest pains or poor EKGs. For BLS cardiac arrest, using an AED, performing what it advises, continual CPR, placing a advanced airway, continuing CPR, listening to the AED. If you do not have ALS available, you must transport immediately. If the AED is advising no shock, just continued CPR, using King Airways or combi tubes, hook them up to capnography, and just follow CPR proper rhythms. For adult cardiac arrest, same algorithms. Treating shockable rhythms, if it is shockable, defibrillations, and continue epi every 3 to 5 minutes for the duration of the code. Intubations for ventricular rhythms, amiodarone, 300 milligrams. Treat reversible causes. If there's no conversion with the 300 amiodarone in 3 to 5 minutes, give 150 dose. Or if you're using lidocaine, 1 to 1.5 milligrams per kilogram, repeated at half that dose, 0.5 to 0.75 at 10 minutes, intervals to a max dose of 3 milligrams per kilogram. If torsades is witnessed, administer mag sulfate 1 gram and 10 cc's over 5 to 20 minutes. If non-shockable rhythm, there's been no change within 20 minutes, refer to the Cease Efforts Protocol 9102. Adult tachycardia for ALS only. The algorithm of if they have a heart rate over 150 and hypotensive or an ultramental status, immediate synchronized cardioversion. For biphasic monitors, 100 joules or the equivalent. If there is no conversion, then repeat at 200 joules, 300, 360, checking for conversion after each shock. If that's not working, contact medical command and consider adenosine. If it is over 150 and they do not have an ultramental status or hypotensive, referring to the other side of the algorithm as if it's wide, give adenosine 6 milligrams rapid IV push, followed with 20 cc flush, second dose of 12 milligrams if required. Consider an antiarrhythmic, amiodarone 150 over 10 minutes. Repeat that 150 if VTAC still occurs, or using the lidocaine 0.5 to 0.75 every 5 to 10 minutes, maximum dose of 3 milligrams per kilogram. If it's narrow, try vagal maneuvers and adenosine, and if that's not working, contact medical command. For symptomatic AFib or aflutter, give Cardiazem 0.25 milligrams per kilogram slow IV. You can repeat that in 15 minutes at 0.35, and this is per order of MCP. For bradycardia at ALS only, if a heart rate is less than 50, perform an IV, do 12 lead if you're able to, and if with any serious signs and symptoms, give atropine at 0.5 milligrams. Repeat that every 3 to 5 minutes up to a maximum dose of 3 milligrams. Give atropine should not delay implementation of pacing if needed. If atropine is ineffective, patient has poor perfusion or high degree AV block, start with pacing first. Consider giving a pre-medication of 2 milligrams of Versed. For pain, you can give 1 microgram per kilogram up to 100 micrograms per single dose IV. If there's no pain relief after 2 minutes, repeat the fentanyl dose at order of the MCP. If the heart rate is not less than 50, just closely monitor the patient. If you need to do a dopamine drip, contact medical command. For the right ventricular acute myocardial infarction, where nitroglycerin will be contraindicated, and this is the 12 lead confirmed with STEMI and V4R. So if nitro is contraindicated, you can go straight to narcotics, give him morphine, 2 milligrams, repeat every 5 minutes up to a total dose of 10. For fentanyl, 1 mic per kilo up to 100 mics single dose. These may be repeated by order of medical command. So return to spontaneous circulation for the patient who was just resuscitated after cardiac arrest. The BLS level, avoid excessive ventilation. If you have capnography, titrate to 35 to 40 millimeters of mercury. Titrate oxygen, maintain a range of 94 to 99%. Consider having a supraglottic airway device in. Hopefully there is one in at this point. Closely monitor ABCs and get ALS backup if available. For all seat the ALS level, same as the BLS level. Provide ventilations of 10 to 12 per minute. Avoid excessive ventilation. Titrate in tidal readings of 35 to 40. Maintain oxygenation 94 to 99%. Intubate. IVs, perform fluid, treat hypotensive per the hypoperfusion or shock protocol. Perform 12 leads and check all the H's and the T's. Transport to facility capable of a PCI. If a patient remains unresponsive after ROS, consider cooling the patient with 250 cc's of normal saline at 4 degrees Celsius. That's applying cold packs to the axilla, the groin, the neck, etc. If you need to do conversion drips of amiodarone or lidocaine, that is per orders of medical command. Bronchospasm treatment is the same for ALS and BLS. For adults, if their heart rate is under 130, give them an ANA treatment of 2.5 milligrams albuterol mixed with 0.5 milligrams of Atrovent. Or if you have the Combivent or Duonebs, use that nebulized 8 to 10 liters a minute. For pediatric patients, if their heart rate is less than 150, you may give them an albuterol treatment only. Atrovent is contraindicated in pediatrics. If you need a second dose of anything, you must contact medical command. If the stress continues and the patient's under 35 years of age, has no history of cardiac disease or hypertension, consider administration of epinephrine 0.3 milligrams IM per MCP order, and that too is ALS and BLS. If the heart rate is over 130 for adults and over 150 for pediatrics, you must confirm that the tachycardia appears to be from respiratory distress, not other causes. Ensure that the high heart rate is because of difficulty in breathing. The difficulty in breathing is not because of a high heart rate. If they're under the age of 35 and no cardiac history, proceed with the ANA treatment. If they have any signs of chest pains or any kind of cardiac thing, contact medical command. For EMT only, if the patient is over 35 years of age and has a cardiac history, you must consult with medical command before you give an ANA treatment. For pulmonary edema, if the patient is in severe respiratory distress, consider CPAP per the CPAP protocol. If the patient has rales and a blood pressure over 180 systolic, you may give nitroglycerin 0.4 every 3 to 5 minutes up to a total dose of 3. You must obtain a manual blood pressure between doses of nitro and assess the patient's response prior to administering subsequent doses. For the EMT, you have standing orders for 1 nitroglycerin, and any repeated doses are per MCP order. For ALS, if the patient does not take Lasix and they have systolic blood pressure over 100, you may give 40 of Lasix. If they do take Lasix, and their blood pressure is fine, give them 80. If wheezing is present, you may also give an ANA treatment, but if it is a pediatric, albuterol only. Any subsequent doses per MCP order. If the patient's hypotensive with rails and JVD, expedite transport and contact medical command. For inhalation injuries, identify what has caused the injury and ask all the questions to figure out the duration, the history, and all that. Just good assessments on that, figuring out what they did. Treating per respective protocols. If for wheezing, treating per bronchospasm. If they're burnt, treating per the burn protocol. And you may contact medical command to help identify treatment plans for the substance they were exposed to. For airway obstruction, follow the simple Heimlich maneuvers. For patients under the age of 1, do 5 back slaps and 5 chest thrusts. Do not do the Heimlich on kids under the age of 1. The chest thrusts are preferred on advanced pregnancy or obesity. Do not perform finger sweeps on children under the age of 8. Just repeat doing your simple Heimlich maneuvers or back slaps and chest thrusts. For ALS, you may consider the optional Crike protocol. Refer to Airway Management 4901 otherwise. Pediatric assessment, just remember the pediatric assessment triangle and doing your hands-on assessments for the A, B, C, D's, and E's. Maintain oxygenation 94 to 99% by blow-by. And as a note, do not use a combi tube in patients under 5 feet tall or less than 70 pounds. For BLS, pediatric hyperperfusion and shock, control any bleeding, prevent heat loss, and consider ALS backup without delaying transport. Then refer to any other protocols that may have caused the hypoperfusion, such as allergic reactions, trauma, or airway issues. For ALS, pediatric hyperperfusion, again, as it was with the adult, there are the categories of shock. The most likely causes of those with hypovolemic, from bleeding, vomiting, diarrhea; distributive, from sepsis or anaphylaxis, toxic chemicals, or spinal cord injury; and cardiogenic, very rare, by congenital heart disease. If hypovolemic shock is suspected, establish an IV, give 20 cc's per kilo. If you need more fluids, per medical command. If they are in decompensated shock, such as low blood pressure, tachypnea, cool clean skin, altered mental status, make one attempt to establish an IV IO and give a bolus and then transport. If still evidence of shock, repeat the dose up to 60 cc's per kilo. If distributed shock is suspected, for anaphylaxis, refer to the anaphylactic protocol. If you need dopamine, that is per MCP order. If cardiogenic shock is suspected, where it was 250 cc's for adult, for the pediatric it's 10 cc's per kilo. And again, if you need dopamine, that is per MCP order. For BLS, pediatric seizures, obtain a good history to understand maybe why they're seizing. If they are fevered, refer to the fever protocol. If it's trauma, refer to that respective protocol. If our glucose is below 60, we're unable to determine it, contact medical command to consider administration of glucose. If a seizure has lasted longer than 5 minutes or has 2 or more episodes of seizure-like activity without regaining consciousness, request ALS backup and begin immediate transport. For ALS, same thing. If a patient has been given prescription for Diastat and is still seizing, administer Diastat per rectum as as prescribed dose and then contact medical command. If that is not available, quickly check blood glucose and then give D10 for the patient who's 1 month or younger if their blood sugar is below 60. So if D10, give 5 to 10 milligrams per kilogram. So that's prepared by mixing 40 cc's of normal saline with 10 cc's of D50. If they're older than 1 but younger than 2, give D25 at 2 to 4 milligrams per kilogram. That's by mixing a 50-50 ratio of D50. So take out 25, fill up the remaining 25 with normal saline. Patients over the age of 2 can get D50 of 1 to 2 milliliters per kilogram, max dose of 25 grams. If no IV is available for the pediatric, if they're under the weight of 20 kilograms, give 0.5 milligrams of glucagon. If they're over 20 kilograms, give 1 milligram of glucagon. If a seizure lasts longer than 5 minutes, if they are in status epilepticus, you need to contact medical command to give an anticonvulsant of Versed. And the dose for that is 0.1 per kilo. Pediatric suspected child abuse protocol basically means that if you detect any kind of child abuse or neglect, you must report that within 48 hours by West Virginia law. So it must be reported to the DHHR, to the hospital staff. All that needs to be reported. Just don't be confrontational on scene and start accusations there. Make these notifications after you've transported the child. If there's any suspicions of sexual abuse, don't allow the patient to go to the bathroom. Don't allow them to change their clothes or wash, and give nothing to them by mouth. For sudden infant death syndrome, basically an overview that you need to just have to comfort the family. Don't make any kind of judgments or accusations towards the family. This is going to be a very difficult time for the family. So consult with medical command if anything else follows, and just following the death and field protocol. For pediatric cardiac arrest, if the child's over the age of 1, perform CPR and use an AED. Manage the airway properly, and if the patient is under the age of 1, perform CPR without an AED and ventilate with a bag valve mask. And request immediate ALS backup. If it's not available, transport immediately. For paramedic, administer epi 1 to 10,000, 0.01 per kilo every 3 to 5 minutes, or you can do it through the ET tube of 0.1 of 1 to 1,000. So giving that ampule of epi through the ET tube. And defibrillate at 2 joules per kilo. If there's no conversion with defibrillation, the next defibrillation can be at 4 joules per kilo every 2 minutes. And continue the epi throughout. For amiodarone and lidocaine, the dose of lidocaine is 1 milligram per kilo, IV or IO. Amiodarone is 5 milligrams per kilogram, IV or IO. Then continue defibrillations at 4 joules per kilo. If assistedly, make sure you turn the gain up, zoom in to make sure it's not very fine V-fib, and then just continue with epi. And again, 0.1 milligrams per kilogram of 1 to 1,000 epi can go in the ET tube, or 1 to 10,000 IV or IO. Pediatric dysrhythmias. To treat any pediatric dysrhythmia, you need to contact medical command. So epi, atropine, first order and respective for bradycardia. If you need to give adenosine, again, medical command. As well as synchronized cardioversion, contact medical command. For trauma assessment, head to toe, scene evaluations, give oxygen, 15 liters, not a breather, maintain oxygenation 94-99%, stabilize, prevent heat loss, control any kind of bleeding, and refer to any protocols that may align. Patients, if they are still in a car seat and the car seat is not damaged, they may still be transported in the car seat. If they're not in a viable car seat, transport using a approved method via your agency. If the patient does have signs and shock, start as large of an IV as possible and give a fluid bolus of 20 cc's per kilo and refer to the shock protocol. If they do not have any signs of shock, fluid at KVO. If the patient is intubated, consider giving a nasogastric tube as long as the patient has no facial trauma. For pediatric fever, if the fever is over 102, do passive cooling just by removing the clothes, turn on the air conditioning. If the child has not been given Tylenol in the last 4 hours, give Tylenol at 15 milligrams per kilogram with the assistance of a parent or guardian to help calm the child. If their fever is over 105, proceed by giving Tylenol as well and applying wet towels, more aggressive cooling. Now for EMT, all this administering Tylenol is per MCP order. Typical care, deliver the baby, dry off quickly, keep the baby as warm as possible, turn on the heat in the back, cover them up with blankets, maintain a good temperature of at least 97 degrees, and checking that every 15 minutes. And with checking the airway and the breathing, put them in the sniffing position, suction the mouth and airway with the bulb syringe as needed, and assess the breathing. Should be 30 to 60 breaths per minute. If there's inadequate respiration, cyanosis, or any kind of grunting respirations or anything similar to that, give oxygen, 15 liters not a breather, held firmly on the infant's face. If there is no response or improvement after 5 to 10 seconds, begin positive pressure ventilation, 40 to 60 breaths per minute. If prolonged ventilation is needed by bag valve mask, consider intubation. For circulation, heart rate should be over 100. If a heart rate's under 100, give oxygen by positive pressure ventilation at 40 to 60 per minute. Reassess after 30 seconds. If there's no improvement, the heart rate is still staying low, continue to ventilate. If the heart rate drops below 80, that's imminent danger. So if a heart rate drops below 60 or persists between 60 and 80, despite good ventilations, give chest compressions. And for ALS, treat per any kind of defibrillator protocol or cardiac arrest protocol. Transport the infant and then be assessing APGAR scores otherwise if you're not performing CPR. So reference of the APGAR score is in this protocol as well. Pediatric diabetic emergencies. This is for ALS only. Similar dosing back to the hypoglycemic or the seizing patient. For under the age of 1 month, give D10 at 5 milligrams per kilogram. 1 to 2, give D25, 2 milligrams per kilogram. If they're over the age of 2, 1 milliliter per kilogram for maximum dose of 25 grams. And for glucagon, if they're under 20 kilograms, give them half a dose of 0.5 milligrams. If they're over 20 kilograms, give 1 milligram. If their blood sugar is over 300 and have signs and symptoms of DKA, such as acoustical respirations, acetone smell, or not taking insulin, give them a fluid bolus of 20 milligrams per kilogram. May repeat once if the glucose is over 300. Pediatric anaphylaxis. Assess the patient well. If they have an EpiPen, contact medical command and give them their prescribed EpiPen. If they do not have a prescribed EpiPen, via medical command If they're under 30 kilograms, that's under 66 pounds, give them the Epi Junior or administer 0.3 milligrams IM per medical command. If the patient is still wheezing after the epinephrine administration, contact medical command. I have orders to give albuterol nebulized. If the patient is still in distress, per that order, give another dose of epinephrine. For ALS, consider giving Benadryl first line if it is not a severe distress. So for pediatrics, 1 milligram per kilogram IM or slow IV with a maximum dose of 25 milligrams. If they're in moderate distress with severe hives or severe distress, administer epinephrine immediately. 0.3 milligrams IM for patients over 30 kilograms, 0.15 milligram IM for patients under 30 kilograms. Then give the Benadryl after the epinephrine. If the patient is still wheezing after the fact, give albuterol. And if they're still moderate distress, consider giving another dose of epi per medical command. For adult allergic reaction for an EMT, similar to the pediatric, if they have a prescribed EpiPen, contact medical command to administer the EpiPen. If they do not have an EpiPen, contact medical command to administer either your EpiPen or administer Epi 1 to 1,000, 0.3 milligrams IM, and all that per MCP order. If they're still wheezing, consider giving an ANA treatment per medical command order. For ALS anaphylaxis, for mild distress, frontline is Benadryl 25 milligrams IM or slow IV or IO, repeated in 30 minutes if those symptoms persist. Transport notify medical command. If it's in severe distress, give Epi 1 to 1,000, 0.3 milligrams IM. Unless the patient's over 50, then that is per MCP order. Then subsequent doses of Benadryl after the Epi of 25 milligrams, again, may be repeated. If they're still wheezing or in distress, you can give the ANA treatment. If you need any more Epi, that is per MCP order. If they are in shock, give a bolus of 20 per kilo. Environmental emergencies and heat exposure. Basically, if they're hot, get them in, get them cool. If they have a normal level of consciousness and are not nauseated, encourage them just to drink some cool water or Gatorade, something like that. For ALS, if they have a decreased level of consciousness or they're vomiting, give a 250 cc bolus and then run at 250 per hour. Then just cool by fanning and air conditioning. If the patient's very hot with dry skin, rapid pulse, altered mental status, experiencing signs and symptoms of a heat stroke at the ALS level, give saline at 250 per hour initially and treat for any kind of shock. Otherwise, ALS and BLS, just keep them cool and get them dried off. Then you may also apply ice packs to the axilla, neck, ankles, and wrist. Do not overcool and watch for shivering. If they start to shiver, they're cool enough. For cold exposure, get them out, get them inside someplace warm. At the ALS level, just start an IV, keep fluids at KVO. Then you'll be encourage them to drink warm drinks, put hot packs or hot bottles into the neck, chest, and abdomen. If the patient has no pulse, perform CPR as long as you've checked for a pulse for at least 60 seconds. At the ALS level, defibrillate at the max joules and withhold medications if until their temperature is above 86 degrees Fahrenheit. For frostbite, Remove all constricting stuff. Do not rub or massage the area or break any blisters. Do not apply direct heat. For snake bites, rule number 1, do not take a live snake to the ER. Keep the patient calm. Remove any jewelry or anything that could become constrictive if they begin to swell. At the ALS level, do not put an IV in the bitten extremity. Locate the fang or the bite marks, and then take out a Sharpie and mark the ring about every 5 minutes to measure how fast it's swelling. Immobilize the extremity at the level of the heart and do not apply ice. No constricting bands, just marking the redness around the bite mark. For near drowning or drowning, move the patient out of the water. Do your assessment. If it's cold water drowning, refer to the cold exposure. Do not begin CPR. Don't give medicines if they're hypothermic. Otherwise, treat them per whatever signs and symptoms they may have. If they're unconscious, assume spinal injury and fully immobilize them. Hypoperfusion shock of the adult for the BLS level. Controlling bleeding, prevent heat loss, and consider ALS backup or air medical. The ALS level, start large bore IVs, and if their blood pressure is low, below 90, give 20 milliliters per kilogram up to a total dose of 2 liters and reassess. If you need to repeat any doses of fluid, that's per medical command. If their blood pressure is above 90, fluid at the KVO rate 100 milliliters per hour. With distributive shock, if they're hypotensive, 20 cc's per kilo. If you need a drip of dopamine, contact medical command. For cardiogenic shock, 250 cc's, and assess for fluid overload. If you need to repeat a dose of the 250 bolus, contact medical command. For stroke, perform the Cincinnati prehospital stroke scale, checking for abnormal speech, facial droop, and arm drift. Immediately check blood glucose levels. At the ALS level, if blood glucose is below 60, administer D50 and titrate to a level above 90 or the patient's level of consciousness increases. Avoid a rapid change in serum glucose levels. Do a 12 lead and initiate fluid at KVO rate and transport to the appropriate stroke center. If possible, get all the information you can from families or have families go with the patients. For seizures at the BLS level, figure out possibly why they're having a seizure. If they are active seizing, protect the airway. Don't place any adjunct or anything in their airway, and obtain information and quickly assess their blood glucose and treat per diabetic. If a seizure lasts longer than 5 minutes, or they have 2 or more episodes of seizure activity without regaining consciousness, immediately request ALS backup without delaying transport and meet en route. For ALS level of seizures, same thing, but if your blood sugar is less than 60, give D50 or glucagon 1 milligram IM. And for status epilepticus, give Versed 2 milligrams IV, IO, or IM, or 5 milligrams intranasally. If they're over the age of 55, smaller doses, 1 milligram IV, IO, or IM, in the same dose via atomizer intranasally. If the patient is not seizing, just BLS comfort measures. For BLS diabetic emergencies, if their blood sugar is less than 60 and they're awake and alert, or awake and confused with blood glucose under 60, give 15 grams of oral glucose and recheck the blood sugar level. If the blood sugar level remains under 60, give a second dose of oral glucose. If the patient is unconscious, has blood glucose under 60, secure the airway and request ALS backup. The ALS level, treating with D50 and glucagon. If their blood glucose is over 300 and have signs and symptoms of DKA, you can give a 1 liter bolus of normal saline and may repeat once if glucose remains above 300. If the patient has a history of end-stage renal disease or is on dialysis or has a history of CHF, bolus gently with 250 milliliters at a time. After each bolus, reassess for fluid overload. For unconscious auto mental status, do the AEIU tips, try to assess why they're unresponsive. Whatever you find, treat as needed. If you can't find anything else out and their blood sugar levels above 60, give Narcan 0.4 milligrams up to a dose of 2 milligrams IV, titrated to restore the respiratory drive. If the IV can't be established or you are BLS, administer 2 milligrams Narcan intranasally via atomizer, making sure 1 milligram goes in each nostril. For overdoses, toxic poisonings, ingested poisonings, secure the airway, don't induce vomiting, transport everything you have that they've ingested. If it's inhaled, get them out of that hazardous environment, figure out what it was, transport anything you can safely with you. For absorbed poisons, figure out what it was, treat per burn protocol if necessary. Foremost, just determine what, when, how much, over what time period, and take whatever you can safely to the hospital. For alcohol, they may be in withdrawal and experience delirium tremens. Also measure their blood sugar. Make sure you don't need to treat per diabetic. If they're in shock, treat per that protocol. If they're seizing, per that protocol. For alcohol withdrawal at the ALS level, you can sedate them with 2 milligrams IV, I or IM of Versed, or 5 milligrams intranasally. If they are over the age of 55, it's half the dose of 1 milligram IV, IO, or IM, or 5 milligrams intranasally. If they're on narcotics, same dose of Narcan, 2 milligrams IV, titrated slowly at 0.4 milligrams per minute to restore respiratory drive. So don't slam 2 milligrams, 0.4 milligrams per minute up to a dose of 2 milligrams, and continue to support ventilations and oxygenation 94 to 99%. For BLS level, give 2 milligrams intranasally, 1 milligram in each nostril. For ALS level, if they've overdosed on TCAs, support the respiratory drive. If they have serious signs and symptoms with an automental status, tachycardia, or a widened QRS, or hypertension, give them a fluid bolus of 20 per kilo. There's no improvement after 2 boluses, then contact medical command for further treatments. Chlorogenics, if they have serious signs and symptoms or they have sludge and with a heart rate under 60, give 2 milligrams IV of atropine. Repeat 5 minutes. Repeat every 5 minutes if needed. So the sludge acronym of salivation, lacrimation, urination, defecation, GI cramping, or emesis. Overdose on calcium channel blockers, atropine 1 milligram IV. If there's no response to that, contact medical command. For beta blockers, serious signs and symptoms, infuse a bolus. If there's no improvement after 220 per kilo boluses, contact medical command for direction. You may administer glucagon 1 milligram IV. If additional glucagon is available, administer 2 milligrams IV as the initial dose. Repeat at 2 milligrams IV in 10 minutes. So if you have enough glucagon, give them 2 milligrams and repeat that in 10 minutes. For stimulants, support the respiratory drive, check for serious signs and symptoms. For tachydysrhythmias, a heart rate over 120, give Versed 2 milligrams, slow IV push, titrate to effect. If the patient is severely agitated, going crazy, refer to the behavioral emergencies or patient restraint protocol. For cyanide exposure, support the respirations with the BVM, administer a cyano kit if you do carry that. If you do not, contact medical command. Behavioral emergencies, make sure that you're going to be safe first and foremost. If you need to physically restrain the patient with commercially available soft restraints or whatever you have to restrain, you must contact medical command to receive orders to do so. At the ALS level, you have standing orders to perform a chemical restraint if they're experiencing psychotic or behavioral agitation. So first, give Versed 5 milligrams IV, IM, or intranasally. For patients over the age of 55, give Versed 2 milligrams IV, IM, or 5 milligrams intranasally. If that doesn't solve the issue with the patient, remain aggressive after 5 minutes, administer 5 milligrams IM of Haldol. If the Haldol causes them to have a dystonic reaction, then give 25 milligrams IV or IM of Benadryl. And always contact medical command. With OB emergencies, asking all the important questions of the length of gestation, number of pregnancies they've had, number of prior pregnancies carried to term, have they ever had a C-section, any OB history, is there any pain, contractions, they feel the urge to push, anything that would relate to them imminently about to deliver. Transport the patient on their left side unless they're in active labor. If the patient's in late stages of pregnancy and shows signs and symptoms of preeclampsia or eclampsia, such as edema, hypertension, hyperreflexes, transport them as smoothly as you can. If a seizure occurs, treat per the seizure protocol. For normal delivery, as the baby comes out, suction the baby's mouth, then the nose, and his head delivered. If the cord's around the neck, slip it out of the way. Repeat the Apgar scale at 1 and 5 minute intervals. If the cord is pulsating, when cord ceases pulsating, clamp at 6 and 8 inches from the navel, cut between the clamps. So clamp 6-8 inches, cut between the clamps. For breech delivery, allow spontaneous delivery and support the presenting part of the body. If the head is not delivered within 4 minutes, insert a gloved hand in the vagina, making a V around the infant's nose and the mouth, getting the head up off the vaginal wall. For prolapsed cord, put a patient in the knee to chest position or on hands and knees with knees to chest. Ask mother to pant during contractions and to not bear down. Insert a gloved hand in there to get the head lifted up off the cord and be checking to make sure there's still circulation of the cord. If a limb presents, just cover it up. Referencing of Apgar score, again, doing that at 1 and 5 minute intervals. For nausea and vomiting, give a 20, as the ALS level, give 20 milliliters per kilogram of fluid bolus as needed, and give 4 milligrams of the oral dissolving tablet or 4 milligrams undiluted IV push over 4 minutes, or give it IM. As an EMT, you can only give the oral dissolving tablet of Zofran. It's 4 milligrams. Just put it in their mouth, let them dissolve. Also at the ALS level, Zofran's contraindicated if they have a prolonged QT interval. These protocols cover children with special health care needs, the general assessment that, using the pediatric assessment triangle, the A, B, C, D's, and E's. Most of the parents of these children with special health care needs have an immense amount of training, so they will be your subject matter experts in your reference on what to do. Just make sure that whenever the child goes to the hospital, bring all the charts, essentially take their go bag, everything that child is going to need for their equipment, whatever they may have, make sure it goes with them. Otherwise, basic care, maintain oxygenation of 94 to 99%. ALS may be necessary for these children with special health care needs. For central venous lines, if the patient has a line on them, just check it out, make sure that it's not infected and red and swelling. This is at BLS level as well. Just look at it, you can't touch it, just let it be. And then comfort measures, making sure they've got their go bag, they're taking everything in the hospital they need, and maintaining oxygen 94 to 99%. For brain shunts, check for fevers, any kind of bulging fontanelles, or an altered change in mental status. Just again, make sure that they're taking all that they need with them to the hospital and assess and treat as need. For the feeding tubes, if they have infusing fluids, stop those infusing fluids, turn it off, have the family flush the tube with water and clamp it off. At the ALS level, begin cardiac monitoring. If you need to give a fluid bolus, that's per medical command. For feeding tubes, again, transport them in semi-Fowler's position, elevate their head 30 to 45 degrees, unless that's contraindicated in such cases as trauma, and make sure they have all their stuff. For apnea monitors, leave it on, take it with them, take everything they need to the hospital. If need be, suction through the nose and mouth or the trach tube. If they have an internal pacemaker defibrillator, if no pulse present, begin CPR and follow as needed. If you're wanting to, the pacemaker should be felt near the clavicle or in the abdomen in younger children. Try to do detective work to figure out possibly why they are in cardiac arrest at the ALS level. Establish IV and IO, treat per shock, cardiac monitoring, full CPR workup. Ventilator support. If there's issues with the ventilator, disconnect it, attach a bag valve mask, and begin manual ventilation. Making sure there's no airway obstructions, listening lung sounds, making sure that if they have a trach that it's not occluded, suctioning is needed, and ensuring that it was a faulty device and not something wrong with the patient. And transport immediately. Airway management. If they're in no or mild distress, give oxygen via nasal cannula, 2 to 6 liters. Maintain oxygen always 94 to 99%. If they're in severe distress, 15 liters, non-breather. Try to perform end-tidal readings via capnography. If the airway cannot be maintained by just oxygenation or simple ventilation, you intubate the patient as a paramedic or an EMT. Use a combi tube or King airway. Airway management at ALS only. If you're unable to ventilate the patient, consider the optional Crike protocol. Once the patient's intubated, if the patient shows evidence or need for sedation or pain management, or able to facilitate tolerating the ET tube, sedate with Versed, 2 milligrams IV or IO every 5 minutes, total dose of 10, as long as the blood pressure stays above 90, and you can give fentanyl, 1 microgram per kilogram up to 100 mics, a single dose. Additional doses of either require MCP order. These doses may also be given IM if you're unable to get an IV or IO. Patient comfort. Standing orders to give fentanyl, 1 microgram per kilogram up to 100 mics, a single dose, repeated per orders, as well as morphine, 2 milligrams IV every 5 minutes up to a dose of 10. Do not give morphine to kids less than 12 years old. Pediatric dose of morphine is 0.05 milligrams per kilogram. For patients over the age of 55, the doses will be 0.5 mics per kilo of fentanyl or 1 milligram of morphine. Use caution if they are borderline hypotensive. Use fentanyl instead. If their blood pressure drops below 90, give a bolus of 250. To prevent nausea, administer Zofran, 4 milligrams IV or IM. The pediatric dose is 0.15. To RSI, this is going to be an optional thing, and this is going to be all under sight of the ALS agency. So we'll skip through this just because that's going to be overseen by the agency, and very few places are currently doing that. This is an optional procedural protocol of the Morgan's lens. This is to irrigate the eye. You administer tetracaine, 2 drops per eye being irrigated. Attach a mixed saline bag to IV tubing. Attach the Morgan's lens to the IV tubing, and then run the fluid to drain out the eyes. Do not run dry. The fluids must always be running over the eye. And again, this is optional. If your agency is using this, they should provide an in-service on how to use this. IO for ALS only. IO is not for prophylactic access. This is for life-threatening stuff, altered mental statuses, pending cardiac arrest, or the patient's just completely circling down the drain. You can use an IO and skip the IV. It's contraindicated in the fracture of the bone selected, absence of anatomical landmark, previous significant orthopedic procedures, infection of the select site. For the adult, going in the order of proximal humerus, proximal tibia, and then distal tibia. For pediatric, proximal tibia, distal tibia, and then proximal humerus. So for adults, go for the shoulder, kids, still the tib. You can see in the pictures here of the places to locate for the IO. For anesthesia, if you're going to put an IO in a conscious awake patient, slowly administer cardiac lidocaine 2%, 100 milligrams in the 5 milliliter dose through the IO. So the dose for adults will be 40 milligrams. That's the 2 milliliters. Slow IO. For pediatric, 0.5 milligrams per kilogram slow. Allow that to work for 30 to 60 seconds before flushing. So for flushing, adults, 10 milliliter of normal saline rapid IO bolus to flush that out. CPAP is indicated for any patient in respiratory distress and who has signs and symptoms with CHF, pulmonary edema, asthma, COPD, or pneumonia, and must meet all 5 of the following criteria. They must be awake and oriented, unless you have the ability to continuously monitor and trend the end-tidal CO2 values and waveform, and must remain with the patient at all times, or if the patient has an altered LOC caused from hypercapnia, then a CPAP may be applied, and the patient continually reassessed for decrease in end-tidal CO2 and improvement in oxygenation, as the increase in SpO2 or the increase in level of consciousness. Or if after 3 to 5 minutes the patient does not respond or their condition worsens, then the CPAP will be discontinued and patient receive positive pressure ventilation via bag valve mask. So awake and oriented unless they meet any of those exceptions, and they must be over the age of 12 and have the ability to fit one of the CPAP masks. Must be able to maintain an open airway, have a systolic blood pressure over 90, and has at least 2 of the following: retractions or accessory muscle use, respiratory rate over 24 minutes, and the inability to speak in full sentences due to dyspnea. Contraindications: respiratory arrest, hypertension, pneumothorax, the trach, they're choking, have facial deformities or vomiting, head, neck, face trauma, or recent gastric surgeries. Some complications you may see is they could develop a tension pneumothorax, hypertension, aspiration, gastric distension, or anxiety. So just explain to the patient, apply everything slowly, put the mask on, and strap it on. CPAP pressure should begin at 3 to 5 centimeters of water. Most patients are only going to require about 5 centimeters of water, but never go above 10 centimeters of water without MCP order. Using caution with portable oxygen, as it can deplete those very, very fast. Most patients improve in 5 to 10 minutes. If no improvement with just CPAP, additional treatment options may be required. ALS only a chest decompression. If you see that they have systolic blood pressure less than 90 in adults or less than 80 in kids with serious signs and symptoms of shock. For mid-clavicular adults, a 14 or 16 gauge 3 1/4 inch IV or a 1 1/4 inch IV for pediatrics. After you've decompressed, attach a one-way flutter valve to catheter using an aspirin chest seal or similar device. Now you may also cut off a fingertip of a latex glove to use as a one-way valve. The optional Crike protocol of using a commercial made thing such as a quick trait, the indications of it, severe upper airway to where they cannot be intubated or have their airway controlled, can have a Crike. Absolute contraindications is for pediatrics, or if you're unable to locate landmarks, or if you just do not have lack of training. With this, you must also be able to have end-tidal readings, so assessing that, breath sounds, rising pulse ox, and monitoring everything after you've used the commercially made device. Once you've put it in, you may use post-procedure management of keeping sedated with Versed and fentanyl. So Versed 2 milligrams IVIO every 5 minutes to a total dose of 10. Fentanyl 1 microgram per kilogram up to 100 mics max. Those same medications may be given IM if IO or IV are not available, and always consult medical command. Stoma and trach suction management, just suction them out as needed. There's a good reference chart in here of the recommended suction catheter depending on the trach tube size. The pressure setting for trach suction should be 50 to 100 for kids, or for adults, older kids, 100 to 120. Most circumstances, you don't need a suction for any more than 5 to 10 seconds. You may need to use 1 to 2 milliliters of saline to suction that out. And give the patient at least a 30-second break between suctioning. The death in the field protocol, the criteria for that is when you see body changes of prolonged death such as decomposition, rigor, lividity, injuries of obvious life death such as decapitation, obvious signs of death, if they've been pulseless apneic in mass casualty incidents where you can't manage that many patients, if you've obtained proper DNR orders, and if there's any kind of resuscitations that pose a danger to the safety of the crew. So procedure for this is contact medical commands immediately, consult with the MCP, protect and preserve the scene, and notify the local medical examiner via your 911 center. If the county is unavailable or they do not call back within 10 minutes, you can call the state medical examiner's office at 1-877-563-0426. Document everything, and oftentimes you're going to be transporting the patient to the hospital or the funeral home of choice. For CEATS efforts, this is direct consult. This is if the CPR has been in progress and there have been no changes or no success. So a full cycle of ALS treatment, unsuccessful in patients, been confirmed pulseless and apneic for at least 20 minutes. If there's proper DNR orders, if BLS resuscitation has been unsuccessful and patient's been confirmed down for at least 20 minutes. If you're just unable to perform the CPR successfully due to exhaustion of all your resources or personnel. So you'll contact medical command, and medical command will make the final decision once you give them all the information of everything going on in the case. And also any pediatric under the age of 12, if CPR has been done, those have to be transported to the hospital. Field trauma triage goes over categories of assessing for P1 or P2 traumas. Big ones are P1 if have an ultramental status less than 9, a gunshot wound to the neck, chest, abdomen, or extremities, hypotensive that's you cannot fix. P2 trauma is respiratory issues with that, penetrating injuries, chest wall instability, 2 or more big bone fractures, crushing or degloving of extremities, pelvic fractures, skull fractures, and paralysis. These are big priorities to determine where to go. Consult medical command to see which facility you should transport to. AMA's diversion policy just goes over that some hospitals may be on diversion because of equipment issues, that they're full, and the diversion statuses they have. Medical command will make notifications of hospitals being on alert status, so contact the medical command to see which hospitals you should go to. And this just goes over more of what the responsibilities of the hospitals are when diverting. Field air medical, if patients generally P1, P2 trauma, they will meet protocols for field air medical. You can always consult with medical command to see if you should use air medical. So some medical criteria for that, for the non-trauma patients, or strokes, myocardial infarction, major overdose of coma, or major burns. Environmental, just if they're out way too far, it's going to take too long to drive to the hospital. So you consult medical command or relay through your 911 center that you need a helicopter, and they'll alert other agencies that come out and land the helicopter for you. There will have to be somebody there. We'll have to communicate with a helicopter, which is most generally always done by local fire departments. So medical communication policy, whenever you're calling in, there are different statuses. So a status 3, that means the provider has already provided care using offline protocol, whether you have standing orders or whatnot. So this is calling in to say you've already done this and you're so far from a hospital, or you've already taken the patient to a hospital, and you call and tell them, give them a status 3 after the fact. You must call the hospital every time a patient is taken to the ER. A status 2 is the patient's provided care and follow protocol to the point where it says consult medical command. So any of the protocols that says consult with an MCP, this is the status 2. You're calling to continue orders or to continue in your protocol. There's a status 1C or status 1 Charlie. C is for consultation, where you'll call, and if you just want to ask questions or get suggestions from a medical command operator, you may do so. A status 1 Delta means direct. That means you want to speak directly to a physician, whether to ALS or BLS level, if you want to attempt something that is not listed in the protocols, or if in the protocol it says you need to speak directly to a physician. The 3 basic methods of contacting medical command is via telephone, landline, cell phone, or via mobile radio. If you're not able to contact medical command by any of the 3 means, and you must attempt all 3 of those as possible, immediately upon arrival to the receiving facility, you must contact medical command and provide a full report and methods that you used to try to communicate with them. If you're unable to communicate with them, you may proceed with the appropriate protocol and tell them afterwards that you did it. You try to call them and you were unable to reach them. If medical command is not contacted prior to leaving the receiving facility, the provider must submit a report in Appendix H to the State Office of EMS on the appropriate form within 48 hours. Failure to do so may be grounds for suspension or even legal action. And this covers examples of calling in of what you need to provide in your report when you call. Patient handoff, basically a summary of that you cannot hand off a care to a lower provider. Say if a paramedic has begun care on a patient, he cannot hand off care to an EMT. In no time can an emergency medical responder be a primary care provider. Also just summarizes that if, say, a paramedic or EMT are working together, if the paramedic wants the EMT to handle the patient, the paramedic must do their full ALS assessment before the EMT can handle the patient by themselves. And the EMT or the lower level care provider must be accepting of the patient. If that is not in agreement, then you must consult medical command to see what to do. Nerve agent is an optional protocol. If your agency has Mark 1 kits, you can be administering those in the event of a nerve agent exposure. If you do not have those Mark 1 kits and you need to provide treatment to somebody that's been exposed to a nerve agent, consult medical command. The LVAD devices, an overview of an LVAD and how it works. The basic covering of this just says that you must look, listen, feel, look and see if there's any alarms going off in the LVAD. Listen, auscultate over the heart to see if you can hear the LVAD running. Feel the control unit, see if it's hot. Try to replace batteries on it if possible. Try to obtain vitals wherever you can. You're generally not going to be able to feel a pulse. You won't get a blood pressure. Pulse ox and waveform and temperatures will be able to work. If they have any kind of dysrhythmias, treat that per protocol. Most LVAD manufacturers don't recommend performing CPR. The only time CPR should be performed on a patient with an LVAD is you have confirmed the pump has stopped by listening for the pump sounds over the heart, and you've done all troubleshooting efforts of connecting wires, changing batteries, changing out what you have to, and the patient's unconscious, unresponsive, no detectable signs of life, and the patient does not have a valid DNR. If you cannot get it to work and the patient does not have a DNR, then you may begin CPR. Generally, any other kind of issues, a patient with an LVAD, consult with medical command of where to send them. Say if a patient with an LVAD is having a stroke, consult with them because only specialty hospitals can treat patients with an LVAD. If you're transporting a patient with an LVAD, make sure you take all the stuff they need with them, such as batteries, chargers, all that stuff. Capnography monitoring is optional. Then here's the fibrinolytic check sheets of the appendix. So for ALS, if you're transporting a STEMI patient, trying to get this list checked out before you get there if you are able to. The diversion alert status form, the form that's used whenever hospitals go into diversion. And a pediatric reference chart of by age and what their vital signs should be, and airway management supplies of based by age and weight of what size blade and size tube and suction catheter and stylets and everything it should be used. Very handy reference. Reference again to the pediatric assessment triangle and the Wombacher scale. In this appendix list several assessment mnemonics that you can use for charting and whatnot. A reference of the GCS scale and approved abbreviations for run sheets and narratives. All these appendices are listed at the very back of the protocols. Reference for how to do the Cincinnati Pre-Hospital Stroke Scale. This would be your Appendix H that you'll send to medical command if you are not able to contact them. Thank you for watching.